Thank you, Ghanshyam sir. Thank you so much. It was such a wonderful talk listening to you. For the next part of the session, I would like to invite Dr. Amit Rauthan. Sir is a HOD and Senior Consultant Medical Oncology at Manipal Hospital, Bangalore. And Sir will be talking about relaying relay. Over to you, sir.
Thank you. Good evening, everyone. Thank you, Nikhil, and thank you, Dr. Amol, for having me here in this meeting. Can I share my slides?
Yes, sir, you can share.
Yeah, thanks. Thanks. I also thank Lily for giving me this opportunity today. Okay, so here we'll. Yeah, so my topic is relaying the relay data, and what we are talking about. Relay, we know, is a randomized trial of looking at combination of ramucirumab plus erlotinib versus erlotinib alone in advanced EGFR mutated non-small cell lung cancer. So Dr. Ghanshyam has set the stage for EGFR mutation treatment and how we look about it and what are the factors we are looking at. There has been data that VEGF is important for EGFR mutation patients, and blocking VEGF has been a strategy which has been looked at. It started off with bevacizumab-based data, combinations with erlotinib were seen, and even ramucirumab has data of using as a combination with TKIs. Now, ramucirumab, we know, is a VEGF receptor 2 monoclonal antibody. So what happens is there. So this was the background of looking at a combination of Cyramza and erlotinib, and it was said that if you blocked VEGF receptor 2, you will be blocking all the VEGF's ligands. You will be blocking A, C, and D. And it was also thought that if you block the EGFR TKI, you're inhibiting tumorigenesis. So there is a synergism which is happening when you're combining both of these mechanisms. And with this, it was taken up in the Relay study. Relay was looking at stage 4 EGFR mutated non-small cell lung cancer patients, advanced disease with EGFR 19 and 21 mutations. This was used as a stratification factor, and it was randomized 1:1 between erlotinib and ramucirumab plus erlotinib. Now here, ramucirumab dose is 10 mg per kg 2 weekly, treatment till progression or toxicity. The primary endpoint was progression-free survival, and secondary endpoint was looking at response rates, overall survival, safety, and duration of response. There was an exploratory endpoint of looking at PFS2. So both the arms were very well balanced in all the factors. About 60% of patients were never smokers in this trial, and 40% of patients had history of smoking. About 55% of patients had EGFR 19 deletion, and 44% of patients had the EGFR 21 mutation. Now, this is the results. Dr. Ghanshyam just showed us the results of Relay. There was a clear improvement in the progression-free survival, which was the primary endpoint of the study. 12.4 months increasing to 19.4 months, clear hazard of 0.591. So it was a clearly significant trial, and it is a positive trial with its PFS advantage. What was important was were there subgroups which showed a difference. And it clearly showed us that all the subgroups showed benefit when you added Cyramza to erlotinib in comparison to erlotinib alone. Especially the question asked was, if you look at the two EGFR mutations separately, we know Dr. Ghanshyam just showed us that 19 does well, the exon 21s don't do so well. And he also showed us in all the previous studies, even with osimertinib as using as a single agent, the exon 21s, we got a median PFS of about 14 months. They were really not doing very well. But here what we see in both these arms, 19 and 21, we have an equally separation of the curves, the PFS going from 11 months to 19.4 months in the exon 21 subgroup, hazards of 0.44, and even in the exon 19, we are getting a similar benefit with the hazards of 0.65. Sorry, the hazards are 0.62 and 0.65 in both of these arms. So clearly what we are seeing, there's an advantage not only in the exon 19 subgroup, there's also an advantage in the exon 21 subgroup. The duration of response was also better, 11 months going to 18 months, which was statistically significant. The question is, when patients progress, we know in EGFR mutation patients, the T790M is the dominant mutation when you treat them with the first or second generation TKI. 60 to 70% of patients develop it. In this trial, all the patients had not been evaluated for a T790 mutation, but the population which was evaluated, we saw that it's the same development of a T790 mutation, whether you treated them with erlotinib or whether you added erlotinib with Cyramza. About 43% and 47% developed a T790 mutation at progression, which could be targeted. There was a PFS2 which has been reported. The PFS2 is again significant, though the medians have not been reached. There is a separation of the curve which is shown. Now, PFS2 for us is important because nowadays we use a lot of PFS2s when we don't have the OS endpoints yet, using it as a sort of a surrogate for overall survival. But here what we saw clearly, there is a separation of the curve. PFS2 is showing a benefit of ramucirumab erlotinib versus erlotinib. But again, we still don't have the OS data. We don't have all the events which have happened. So the OS data is not yet mature for reporting. The other question which always comes up in the mind is, we are adding a VEGF inhibitor. What will be the toxicity? We know erlotinib is a very safe drug and all of us are very comfortable using TKIs. But what would happen if you use a long-term anti-VEGF monoclonal antibody? So this is anti-VEGF receptor monoclonal antibody. So that's the other thought, that would it be different and would adding this strategy increase toxicity? So we did see that there was higher grade 3 adverse events when you added Cyramza to erlotinib. 53% went up to 71%. But again, if you see the serious adverse events, 20%, 29%, not very different. And discontinuation of the study drug due to serious events, again, not very different, 10.7 versus 12.7%. So what was it which was causing higher toxicity? Now, the three toxicities which we talk of whenever we use a VEGF strategy, we talk of hypertension, we talk of proteinuria and bleeding. And the maximum worry of us for everyone who uses an anti-VEGF strategy is, will the hemorrhages and bleeding episodes be more? And will it complicate the matter in lung? Especially we worry about this. But what was seen here in the real that
Aram, I think we lost her in between.
Yes, sir, I think sir has network issues.
Okay. So can we get her back on?
So we can just call him, or we'll just wait for a minute. He will definitely join.
Yeah,
Yes,
by that time Dr. Amit joins actually. So I'll just share my experience. So I've started 2 patients on L858R. Both are elderly, EGFR mutated, and so both are on this regimen of relay. So at this point of time, 2 months are over now. The patients are doing well, except like the erlotinib toxicities. So I have now moved from 150 to 100. Otherwise, Cyramza, as we have used in lung cancers and others, so it is absolutely safe. So far, so maybe next month we'll be evaluating both these patients. And
so this is actually so true, because everyone, this is to join, put everyone on osimertinib and then forget about it, be it whatever mutation. And so we could, when we showed the data of 14 months, that time really showed that we should think differently.
Yeah, Dr. Amit has joined back, so we'll continue. Yeah.
Yeah, I'm sorry, I lost connection. Actually, I was in my second last slide, so I'll just present it off without the slide. If that's fine. So I was just talking of the toxicity. We had more hypertension, which is expected with anti-VEGF. Again, these are the ones which were the most important grade 3 events. 24% hypertension, and there was more proteinuria as expected. So there was actually no major toxicities more than what we would expect, except these 3 toxicities. So it was pretty well tolerated, even though we added Cyramza to erlotinib. So with this, I would like to summarize. Cyramza erlotinib significantly improved the median progression-free survival. We saw pre-FS going up from 12.4 months to 19.4 months by adding Cyramza, hazards of 0.59. We saw a consistent benefit in both the subgroups. Exon 19 is doing well, but even the exon 21s, which usually don't do very well, where we had a median PFS of 19.4 months by adding Cyramza to erlotinib. The safety is consistent with the established safety profiles, what we expect with a VEGF strategy. Again, no major bleeding episodes, no major issues in terms of adding added toxicity. The EGFR T790M rates at progression were similar between both the treatment groups. And definitely this is also one of the options to consider in treatment with EGFR mutated non-small cell lung cancers. Definitely we will have to learn where this will fit into our place for our patients, which patient subgroup will this be better, but there is a lot of leaning towards exon 21 kind of a subgroup. So with this, I would like to thank everyone. Thank you.
Yeah, thank you, Dr. Amit. Actually, before we lost, so I was discussing, I had started 2 patients on the relay, and both of them are presently doing good. So they are yet to be evaluation has to be done. So both have landed up with the erlotinib toxicity at this moment. So
Right.
the male, elderly male of 80 years who actually had a hemoptysis prior to starting of Cyramza. So I thought, should I start or not? In fact, on the day 10, by the time he came for the second dose, his hemoptysis also improved. So that was a clinical improvement.
Oh, that's excellent. That's really very good. And this was exon 21 patients. How did you choose
both these patients are exon 21. So they are typically on the relay only. So just to have a taste of or you can say the experience. So, but both have moved to erlotinib 100 from 150 because lots of skin toxicity was happening.
Right, that's very interesting. Actually, that's the patient group we are also leaning towards. That exon 21 is where we will be thinking about it. Exon 21 and no brain metastasis. That's where we are leaning.
Yeah,
towards.
absolutely.
That's where we are leaning to. Yes, sir. Anyone would like to have any questions for Dr. Ghanshyam sir or Dr. Amit? Because we have 2 minutes. If there are no questions forthcoming, sir, I would just like to ask about it, sir. Whenever a new patient comes to you, what all do you offer as the first line regimen? So, to either one of you, sir. As in, suppose it's an exon 19 mutation, do you offer EGFR with, do you offer TKI with chemotherapy also as an option? And do you offer Cyramza with TKI also as an option?
So for us, I think for me, when I choose fish, I look at the 1921 and I look at brain metastasis. So if there is brain metastasis, then I directly go towards osimertinib. That's one thing.
Yeah.
Now, if I don't have a brain metastasis, then I am actually, I do use a lot of chemo plus first generation TKI. We have seen the results and we have seen our own patients doing very well for long term, and we are reserving the osimertinib as a sequence. So that's something that we are definitely doing for our patients in practice. But again, in the COVID era now, again, giving chemo, calling them for chemo is becoming a little tricky. So again, our inclinations are changing. Now, for the 21s is where we start thinking, should we do differently? And we keep thinking, should we do dacomitinib or should we do a combination of Cyramza and erlotinib? So I still don't have too much experience of Cyramza. Dr. Ghanshyam's patients, I think, are the initial patients where we will learn from such patients and such usage. So I think Dr. Ghanshyam's inputs will be good in this.
Yeah, so as Dr. Amit says, so only first generation TKI alone has no role. So definitely like the ALK inhibitors, so ALK patients, no. So probably we need to do an MRI brain for EGFR also, because 30% of these patients can have a brain metastasis. But at probably previous thinking was that this patient doesn't have much. So so once there is a brain metastasis and if they can afford, so definitely osimertinib is the choice. Otherwise, young fit patients, so chemotherapy and any of these gefitinib is a good combinations. If oral, so my sequence is usually a second generation like afatinib followed by On progression, I go for the third generation. And these are the only 2 patients of L858R where we have started just to get a hang of this. So it is very early to say. Even last week, Tony Mock was not much in favor of the relay. So he said it is too early to say that 19 and 21 are means probably the relay. So these are each individual's perspective. So probably time will say so how things goes on.
That is so nice to hear, sir. But yes, relay the data looks very promising, sir. For the next session, which will be on ALK inhibitors, I would like to call on Dr. Bhavesh Poladia, sir. Sir is a senior consultant medical oncologist at Thangam Specialty Hospital, and he will talk on the landscape of ALK alteration in non-small cell lung cancer. Over to you, sir, and good evening.